Welcome to the deep dive. Today, we're really getting into the nuts and bolts of vascular surgery.
Absolutely. We're talking about surgical exposures and endovascular techniques, foundational stuff.
Exactly. Stuff you just have to master to give patients the best care. Think of this as, I guess, a focus guide, the key strategies you need.
And we're drawing heavily from chapters 55 through 64 of Rutherford's, the gold standard.
Right. This isn't just a skim through, it's a deep exploration, really extracting the practical, actionable know-how.
Our mission, if you like, is to equip you with those key anatomical points, the surgical approaches, the endo-basics.
Without the overload. Just what you need to approach these cases confidently.
Now, Chapter 55 on thoracic and thoraco-abdominal exposures. It's not in our specific excerpts here, but we should mention it.
Yeah, good point. Understanding how to get access way up in the chest and abdomen, that really sets the stage, doesn't it?
It absolutely does. Those principles definitely inform how we approach vessels further down the line.
Okay, so let's dive into Chapter 56, abdominal vascular exposures. When we're near the aorta, the iliacs, what are those really critical relationships we have to keep front and center?
Well, one huge one is the ureters crossing the iliac arteries. Seems basic, but
It's crucial, especially in redos, right?
exactly. Adhesions can make things really tough. That's why thinking about preoperative ureteral stents is so important. It's not just finding them.
It's preventing a potentially massive complication. Injury there can lead to kidney issues. It's all about that careful planning.
Definitely. And thinking about what else is back there.
Right. What else do we need to avoid?
The lymphatics, specifically the cisterna chyli and the thoracic duct. They're right behind the aorta.
Ah, okay. And nicking those can cause a chylous leak.
Precisely. And that's a real pain. Can be morbid, needs more intervention, longer recovery. So careful dissection, knowing where they are, it's paramount.
Okay. Moving up now, Chapter 57 takes us to the neck and upper chest carotids and subclavians. The aortic arch itself can throw some curveballs anatomically, can't it?
Oh, absolutely. The standard three-branch pattern is common, but variations are definitely out there.
Like what?
Well, sometimes the left common carotid comes off the innominate artery. That's a bovine arch variation.
Right.
And the vertebral arteries, they usually come off the subclavians, but, sometimes they originate elsewhere, maybe even straight off the arch. You need to spot these on imaging beforehand.
For sure. And what about that aberrant right subclavian artery? What's the big deal there?
That's the one that arises last, usually distal to the left subclavian, and crosses behind the esophagus.
Ah, so it can cause swallowing problems, dysphagia?
It can, or even respiratory symptoms if it compresses the trachea. Plus, it complicates surgical exposure up there. Knowing it's there preoperatively is key.
Makes sense. Now, let's get specific about exposing the carotid bifurcation. Figure 57.4 shows it well. Which cranial nerves are we most worried about?
Oh yeah, that figure's a great reminder. You've got a whole constellation there. The vagus nerve, cranial nerve 10.
Voice and swallowing.
Right. Then the hypoglossal nerve 12 for tongue movement. The superior laryngeal nerve affects pitch. The recurrent laryngeal, also critical for the vocal cords. And don't forget the marginal mandibular branch of the facial nerve 7 for the lower lip.
Wow. So meticulous dissection is absolutely non-negotiable there.
Couldn't agree more. You have to know that anatomy cold.
And practically speaking, how do we get there? What are the typical incisions for carotid and subclavian access? Figure 57.10 shows a few.
So for standard carotid exposure, it's usually that longitudinal incision along the front edge of the sternocleidomastoid muscle. Gives you a good view.
Okay.
Many incisions are shorter, maybe more transverse for more limited disease. For the subclavian, it's typically a supraclavicular incision running just above and parallel to the clavicle.
And the choice depends on?
Pathology, the patient's anatomy, what the surgeon prefers, really.
Got it. What about subclavian artery transposition to the common carotid? Figure 57.101 illustrates it. I assume keeping blood flow to the brain with a shunt is often a consideration.
Absolutely critical in many cases. As the figure shows, if you've got significant blockage in the carotid on that side, or the other carotid isn't great, a shunt helps maintain perfusion while you're working.
You decide based on monitoring and patient risk factors.
Exactly. Intraoperative monitoring, like EEG or stump pressures, helps guide that decision.
The supraclavicular approach to the subclavian sounds like a careful step-by-step dissection. Can you walk us through the key landmarks and layers?
It is very systematic. You start by dividing the platysma muscle, then the superficial cervical fascia. The external jugular vein often gets in the way.
So you ligate it?
Often, yes.
Hmm.
Ligate and divide for better access.
Hmm.
Then you dissect medial to the internal jugular vein and the vagus nerve, staying in that prescaling fat pad.
Okay.
Identifying and isolating the common carotid artery first is a good landmark. And all through this, you got to be super careful not to pop into the pleural cavity below or yank on the vagus or the phrenic nerve. They're right there.
Are there differences between the left and right side for this approach?
Yes, definitely. On the left, you have the thoracic duct. It crosses right near the junction of the subclavian and internal jugular veins.
So you need to find it and potentially ligate it to prevent a chyle leak.
That's the goal. On the right side, it's usually not an issue, but you have to be aware, rarely, there can be a right-sided duct, especially if there are other anomalies, like that aberrant right subclavian we mentioned.
Interesting. Now, if you need to get more distal or more proximal on the subclavian, things get even tighter, don't they? What are the hazards?
They do. Going distally, you retract the SCM and subhyoid muscles medially. The vertebral vein needs to be found, ligated, and divided.
And that's near the sympathetic ganglion, Horner syndrome risk.
Exactly right. Injury there causes Horner's, the droopy eyelid, small pupil, lack of sweating. So very careful technique. You also need to control the vertebral and internal mammary arteries, the first branches.
And proximally.
Proximally, the vagus nerve crosses anteriorly.
Right.
And on the left, the recurrent laryngeal nerve loops around posteriorly. Both need meticulous preservation to avoid voice issues. The left side is generally a bit deeper, too.
Makes sense. Carotid subclavian bypass figure 57.14 shows the thyrocervical trunk nearby. You mentioned it's similar to a TOS exposure.
The initial exposure is very similar, yeah.
Okay.
Supraclavicular incision, maybe 6 centimeters long, above the clavicle. Divide the clavicular head of the SCM.
Okay.
Then you find the anterior scaling muscle, key landmark. You need to divide it sharply, but only after you've found and protected the phrenic nerve, which runs right on its surface. Use a vessel loop, gently retract it.
And be careful with cautery near the brachial plexus.
Absolutely. It's right there, posterior and lateral. Thermal injury is bad news. Once the scalene is divided, the thyrocervical trunk, as shown in the figure, comes into view. You might need to divide it or just control it with loops to get enough length on the subclavian for the bypass. Proximal control is usually distal to the vertebral and internal mammary origins.
Okay, let's shift gears to the lower extremity. Chapter 58, peripheral artery exposures. It starts with some general surgical principles. What are those core ideas we should always follow?
These are really the fundamentals. Use cautery liberally for dissection, except right near nerves, use sharp dissection there.
Yeah.
Ligate all the lymphatic channels you cut. Meticulous hemostasis is obviously key. Basic surgical technique, traction, counter-traction, keeping the field bloodless if you can, maybe with a tourniquet.
Sharp and blunt dissection close to the artery.
Exactly. Get proximal and distal control with enough room to work. Handle vein grafts super gently, they're delicate. And avoid clamping heavily calcified spots if you can help it. You don't want to break off plaque.
Got it. So, specific approaches. The mid-popliteal artery from behind the posterior approach, figure 58.6. What are we seeing there?
This is often for popliteal aneurysms. Patients prone, knees slightly bent, usually an S-shaped incision to avoid crossing the knee crease directly.
Prevents contracture.
Yeah. You'll find the small saphenous vein and the sural nerve retract those. Then the tibial nerve is the big one, most superficial. Retract it laterally, along with the common peroneal nerve.
And the vessels.
The popliteal artery and vein are deeper and medial to the nerves. You separate the heads of the gastrocnemius muscle to get good distal exposure, but getting really far proximal up into Hunter's Canal is tough from this posterior approach.
Okay. What about the popliteal artery below the knee, the infrageniculate part? Medial exposure seems common.
It is. Patient supine, knee bent, leg externally rotated. Incision below the medial tibial plateau, usually above the great saphenous vein.
Protect that vein, especially if you might use it for the bypass.
Absolutely. Incise the deep fascia. You might need to cut part of the semimembranosus tendon attachment proximally, then retract the medial head of the gastrocnemius back.
And the vessels are right there.
Pretty much. You'll usually see the paired popliteal veins first. They're a bit more superficial and posterior to the artery in that spot.
Moving down again, posterior tibial artery, medial approach. Figure 58.10. Same incision as for harvesting the saphenous vein sometimes.
Often, yes. Longitudinal incision behind the medial edge of the tibia. Incise the deep fascia. Then you need to carefully detach the soleus muscle from the tibia.
Exposes the deeper structures.
Right. The posterior tibial vessels and nerve are right there. Typically, the vein is a bit anterior, maybe overlapping the artery, and the nerve is posterior and slightly lateral. Lots of small connecting veins and arterial branches to lag it.
Vessel loops for control? Tourniquet helpful?
Yes, loops are standard. A proximal tourniquet can definitely help keep the field dry.
And distally, near the ankle. Figure 58.11 shows the approach anterior to the Achilles.
Correct. Incision behind the medial malleolus in front of the Achilles tendon. The artery and veins are usually in some fatty tissue there.
Doppler helpful.
Very helpful, especially distally where things are smaller and more superficial. You'll always find small crossing veins that need careful division to expose the artery properly.
Now, the peroneal artery. Sounds like a tougher one to get to, deeper. Medial and lateral approaches described in figures 58.12 and 13. What's the difference?
It is deeper, so yeah, often a longer incision, especially medially. For the medial approach, detaching the soleus is key again. Then you can dissect either in front of or behind the posterior tibial bundle.
Challenges either way.
Yeah, going anterior can be messy with all the veins connecting the posterior tibial and peroneal systems. Going posterior risks the peroneal nerve. Palpating the fibula helps guide you. Doppler is crucial.
Artery usually posterior to the vein in the medial approach.
Usually, yes. And might be under the flexor hallucis longus muscle. Retractors are essential. The lateral approach, though, many prefer it.
How's that done?
Incision right over the fibula. Free up the muscle attachments, then divide the fibula itself carefully. Incise the membrane underneath, and the peroneal artery and vein are usually right there, fairly superficial actually, with the artery typically anterior to the vein in this view. Good for distal exposure.
Okay. Lastly for this chapter, the anterior tibial and dorsalis pedis. Understanding their path is key for distal bypasses.
Absolutely. The anterior tibial comes off the popliteal, pops through the interosseous membrane into the front compartment, runs down next to the tibialis anterior muscle.
Gets more superficial near the ankle.
Yeah. Crosses the tibia, becomes the dorsalis pedis under the extensor retinacula, runs lateral to the big toe extensor tendon on the top of the foot. Forms part of the plantar arch.
And the posterior tibial contributes too.
Big time. Runs down the back, enters the foot behind the medial malleolus, also feeds into the plantar arches. Knowing both systems and their connections is vital for planning those really distal foot bypasses.
All right, chapter 59 takes us to the upper extremity. The idea of dividing it into intrathoracic, thoracic outlet, and arm zones seems useful. Figure 59.1 shows this. Why is this zoning important?
It's really helpful for thinking about exposure challenges and trauma. Intrathoracic access means big operations like sternotomy, more involved, higher risk, especially in emergencies. The thoracic outlet is that tight space clavicle, first rib, scalene muscles, lots of critical nerves and vessels packed in there. It requires really meticulous work.
And the arm itself?
Generally more straightforward. Vessels are more superficial. You can often use a tourniquet, which is a big help, especially for trauma.
Let's start inside the chest, exposing those major arteries. Figure 59.3 gives some examples. Needs a good handle on that arch anatomy we discussed.
Absolutely. For the innominate right subclavian, left common carotid, proximal left subclavian, a median sternotomy gives great central access.
How do you get down to them?
Carefully dissect through the mediastimal fat and tissue. Mobilize and retract the big veins, like the brachiocephalic veins, out of the way to see the artery origins.
Can you extend that incision?
Yeah, you can extend the sternotomy up into the neck or combine it with taking out part of the clavicle to get more distal access to the carotid or subclavian as they head towards the outlet.
Limitation.
The sternocleidomastoid and anterior scalene muscles can still block your view of the subclavian somewhat, even with the sternotomy. But you can often see the vertebral artery origins well. And you must know where that left recurrent laryngeal nerve is looping under the arch.
What about emergencies involving the left subclavian?
Especially proximal injuries in an unstable patient. You really want to think twice about a massive open exposure, maybe limited thoracotomy for control, or even endovascular balloon occlusion first.
Makes sense. Now, exposing the subclavian directly, say for TOS or an aneurysm there, usually means a supraclavicular incision. Figure 59.8 highlights the phrenic nerve. Tell us about that exposure.
Right. Supraclavicular incision, often in a skin crease. Cut the platysma, then the clavicular head of the SCM. Divide the omohyoid muscle. Retract the prescalene fat pad.
And there's the anterior scalene muscle.
Exactly. And running right across its front surface, laterally to medially, is the phrenic nerve. Figure 59.8 shows it perfectly. You have to find it, protect it carefully with a vessel loop. Nicking that can paralyze the diaphragm on that side.
Significant respiratory problems.
Huge. And be aware of variations. Sometimes it's duplicated.
Subclavian vein exposure, especially for venous TOS, often involves taking out the first rib. Figure 59.6. Claviculectomy is another option.
Yeah, for venous TOS, an infraclavicular incision over the first rib is common. Split or divide the pectoralis major. Take out the fat pad. Find the bottom edge of the first rib.
Veins lateral to the rib.
Usually lateral and a bit superior. You follow it medially. Resect the subclavius muscle off the clavicle. Then you deal with the fibrotic stuff, the thickened subclavius tendon, costed clavicular ligament. That's what's causing the compression.
Divide the anterior scaling too?
Yes, divide the anterior scaling, reflect the middle scaling back to expose the whole rib, then divide the rib front and back and take it out. Then you free up the vein from any scar tissue.
How do you get more proximal or distal exposure?
Rotating the sternoclavicular joint helps proximally. Distally is usually easy through soft tissue dissection. Claviculectomy, taking out the clavicle, gives fantastic exposure of both artery and vein, but can cause some shoulder weakness. Useful in complex cases, though.
Axillary artery, figures 59.9, 59.11, below the clavicle, superior to the vein.
That's the usual relationship, artery above the vein. An infraclavicular approach works well for distal subclavian, proximal metaxillary. Paraclavicular approaches incisions above and below the clavicle are for getting proximal and distal control, like for aneurysms.
Sometimes need to take the clavicle out.
Can be necessary for direct access to a lesion or in tricky redos. Gives much better exposure. For an AXFEM bypass, you usually want a more medial exposure, closer to the origin.
Okay, down into the arm itself. Brachial, radial, ulnar arteries. Sounds more direct. Maybe use a tourniquet. Figures 59.1 and 12 show the brachial.
Yeah, arm exposures are generally less complex. Upper arm, longitudinal incision medial to the biceps, below the deltoid insertion. The neurovascular bundle is there.
Artery deep to vein and nerve.
Usually, yes. Artery deep, vein, more superficial, median nerve, usually medial or overlying. You absolutely have to preserve that median nerve. Superficial sensory nerves can often be divided without major issues.
Can sacrifice a deep brachial vein?
Sometimes, yes.
Yeah.
One of the paired deep veins can often go, which is useful for creating certain AV fistulas, like brachiobasilic transpositions.
And down at the elbow crease, the antecubital fossa. Key for AV access.
Very key. Usually a transverse incision just below the crease for a standard brachiocephalic fistula. If you have to cross the crease, use a longitudinal or lazy S-cut to avoid contracture.
Can get the proximal radial artery here too?
You can. And that bicipital ponderosis, that fibrous band from the biceps tendon, often covers the artery and needs to be opened. Knowing your vein anatomy here, cephalic, median antecubital, basilic perforators, is critical for fistula planning.
Radial and ulnar at the wrist also important for fistulas. Figures 59.14 and 15 for the radial, including the snuff box.
Radial is pretty easy. Longitudinal incision over its pulse, just radial to the flexor carpi radialis tendon. The anatomical snuff box, that depression on the back of the thumb side, is a more distal option.
Artery runs through the floor there.
Yep, accessible for anastomosis. Ulnar artery. Less commonly used for primary access because it's the main supply to the hand via the superficial arch. If you need it, follow the pulse on the ulnar side of the wrist.
All right, chapter 60 takes us to a very different area. Vascular exposure for spine surgery. Patients might be different from typical vascular cases. Figures 60.1 to 60.7 show the lumbosacral anatomy.
That's a really important point. Spine patients are often younger, maybe less atherosclerosis overall. The anterior approach gives the spine surgeon fantastic direct access to the discs and vertebral bodies. Great visualization.
How do you get there? Abdominally or avoiding the peritoneum?
Both options exist for the lumbosacral spine. Transperitoneal means going through the abdominal cavity, extensive bowel mobilization needed, risk of ileus, maybe retrograde ejaculation in men from nerve manipulation.
Laparoscopic transperitoneal.
Hasn't really shown huge benefits over open retroperitoneal.
Yeah.
Can take longer for multiple levels, maybe not great exposure sometimes. And those endoscopic lateral transpsoas approaches have had issues with nerve problems in the groin and thigh.
So the anterior retroperitoneal approach is generally favored.
For open exposure, yes, usually a flank incision. Similar advantages to retroperitoneal aortoiliac surgery, quick exposure, even for multiple levels, fewer intra-op complications usually. Still needs careful mobilization of ureters, gonadal vessels, etc.
The anatomy looks packed. Aorta, vena cava, iliacs, smaller vessels. What are the key things to watch out for?
It is very crowded. As those figures show, the aorta and IVC are right on the spine. Iliacs branch around L4, L5. The inferior mesenteric artery comes off around L3. Segmental arteries and veins at each level need control.
And that iliolumbar vein looks important in figures 60.3 and 60.7.
Crucial, especially for L4, L5, and L5S1 exposure. It drains into the common iliac vein. You have to find it and divide it, or you can get major bleeding.
Other small vessels. Sympathetic nerves.
Middle sacral artery and vein at L5S1. And yes, the sympathetic plexus runs along the sides, need to protect it carefully to avoid sexual dysfunction.
Those self-retaining retractors in figure 60.4 look essential for keeping things out of the way.
They absolutely are. Systems like the OmniTract use specialized angled blades, like renal vein retractors, hug the disc base laterally, retract the big vessels and peritoneum.
Placement relative to the sympathetic chains.
Usually just medial to the chains to minimize injury risk, and you need to release the retraction intermittently to prevent clots forming, especially if there's underlying atherosclerosis.
Hemostasis afterwards. Check pulses.
Yeah, fibrin sealant can help on the spine itself, and always check and document pedal pulses at the end.
Reoperations sound much tougher here. Scarring, things stuck together.
Definitely higher risk. Scar tissue makes dissection hard, increases risk of injuring the vessels. Need meticulous planning, review old op notes, imaging, be ready for tough dissection, potential bleeding.
Repairing vessels is harder too.
Yes, use pledgeted sutures. Big venous tears might need side-biting clamps. Rarely, you might even have to cut and reconstruct an iliac artery just to fix a major vein injury. Most complications are venous injuries, though.
Post-op risks also higher.
Yeah, bowel obstruction from adhesions, hernias if peritoneal defects aren't closed. Higher rates generally with obesity, prior surgeries, multi-level work, re-ops, hardware removal, more blood loss. The vascular surgeon's role here, especially in complex cases, is vital.
Okay, penultimate chapter, 61, basic open vascular techniques. Even with all the endo advances, open skills are still critical, aren't they?
Absolutely essential. Endo is fantastic, but open surgery often offers better long-term durability for some big reconstructions, like complex aortic work.
And for hybrid procedures.
Exactly, combining open and endo. Debranching procedures for complex aneurysms often need open techniques. And sometimes, for really bad limb ischemia with lots of calcium or long blockages, open bypass just works better long-term.
What makes for successful open surgery?
Good planning, right procedure, right time. Optimal exposure, careful, efficient execution. Choosing the right inflow, outflow, conduit vein, or graft. Using the right tools, grafts, sutures.
Basic principles matter too, like lighting, loops.
Hugely important. Avoid touching skin when suturing or tunneling grafts. Use drapes, pads. Good light, magnification with loops. Good posture for the surgeon prevents fatigue and errors, often overlooked, but key.
Let's talk tools. Vascular clamps, table 61.1, and those e-figs show lots. What's special about them?
They have fine serrations designed to hold the vessel without crushing it. Lots of shapes, angles, sizes for different spots. H-matic inserts for grafts. Bulldogs for smaller vessels. Choosing the right clamp is crucial to avoid injury.
Needle holders, forceps, scissors also specialized. E-figs 61.3 to 18.
Yep. Mayo Hagar for bigger needles, Castro Viejo for fine ones. Forceps like DeBakey or Gerald have fine, non-traumatic tips for handling vessel walls gently. Ring forceps like Gerald are great for maneuvering vein grafts.
And scissors.
Metz and Baum for blunt dissection. Church are similar, maybe shorter. Stevens tenotomy are very fine for tiny vessels. Platt scissors have angled tips, specifically for cutting arteriotomies for anastomosis. And right-angle clamps are essential for passing sutures around vessels.
Self-retaining retractors, Omniflex, Bookwalter, and e-figs 61.20-21. They free up hands, right?
Exactly. Provide stable exposure without needing assistance to hold retractors constantly. Omniflex and Bookwalter are great for big abdominal cases like aortic surgery, White-Laner, Addison for neck, or extremity work.
Others for specific situations.
Miscomon can help lift a large pannus in obese patients for groin access. Spring retractors for lower leg vessels. Gelpi for first rib resection.
Sutures, non-absorbable monofilament usually. Table 61.2 has needle sizes.
Right. Polypropylene, polybutester, Novafil, PTFE, Gore-Tex suture. Strong, smooth, durable. Braided sutures like silk are usually just for tying off small bleeders, not for sewing vessels together too thrombogenic.
Double-arm needles.
PTFE knots, tricky. Double-armed helps with continuous suturing. Keeps sutures and gloves moist so they slide nicely. And yes, PTFE sutures need careful knot tying, maybe extra throws, as they can slip more easily. Graft choice depends Dacron often for aorta, Dacron or PTFE for legs, but autogenous vein is best for small arteries if available.
Getting the initial exposure, direct route, landmarks.
Yep, most direct path. Feel for the pulse, know your landmarks. Try to dissect between muscles, not cut through them. If you're cutting lots of muscle, you might be in the wrong plane.
Soft tissue handling, ligate lymphatics.
Always ligate lymphatics you cut to prevent leaks. Avoid cautery, right on lymph nodes. Gently retract the adventitia to skeletonize the vessel for clamping. Use vessel loops or tapes for gentle traction.
Balloon thromboembolectomy, figure 61.29, for acute clots.
Exactly. Acute occlusion from thrombus or embolus. Fogarty catheter goes in proximal past the clot, inflate balloon gently, pull back to extract the clot.
Specialized catheters for tough clots, e-fig 61.28.
Yeah, adherent clot catheters, graft thrombectomy catheters have textured surfaces to grab stickier stuff.
How do you avoid hurting the vessel?
Choose the right size catheter. Test the balloon first. Use minimum inflation needed. Estimate the distance so you don't go too far. Inflate and pull gently. Adjust inflation as you feel resistance. Special techniques for tiny tibial vessels bending the tip, maybe 2 catheters, guiding catheters, over the wire balloons.
Chapter 61 also covers endarterectomy, cleaning plaque out. Open, semi-closed, eversion, or fissure, figures 61.3237.
Right. Open endarterectomy. Longitudinal cut. Find the plane between plaque and outer wall. Use an elevator like a freer. Dissect it out. Feather the end or cut it sharply, maybe tack down any flaps, figure 61.33. Check carefully for any leftover bits.
Semi-closed.
Small cuts, proximal and distal. Use special strippers to core out the plaque, often followed by angioplasty stenting,
You have a version.
mostly for carotid.
Yeah.
Cut the artery across, turn the wall inside out, lift the plaque off, cut the end sharply. Or official, 61.37 is similar, but for branch openings.
Closing the arteriotomy. Primary or patch.
Primary closure, when running suture, works if the vessel's healthy or after a prosthetic bypass. Interrupted sutures, 61.39 if there's still some plaque. Patch closure, vein or prosthetic material, widens the lumen, prevents narrowing. Common in carotid.
Repairing cut vessels. Anastomoses.
Small branches can be tied off. Larger ones need running suture, maybe double layer for high pressure. End-to-end anastomosis often uses spatulation, cutting the ends at an angle, and maybe a 4-quadrant technique for small vessels to prevent narrowing.
Endicide.
Anchor sutures at heel and toe, figure 61.46. Triangulation method helps keep end-to-end symmetric. If you can't move the vessels much, suture the back wall first. T-junction, 61.5 here, and side-to-side are other options.
And those vein cuffs for prosthetic to small artery connections. Miller, Taylor, St. Mary's boot, figures 61.5254.
Yeah, specialized techniques mainly for leg bypasses. Miller cuff, 61.52, uses a patch of vein. Taylor patch, 61.53 is similar. St. Mary's boot, figure 61.54, creates a compliant collar. All aim to improve flow dynamics and patency at that tricky transition point. Each has pros and cons, some are technically harder.
Okay, final chapter for today. 62 endovascular diagnostic techniques. Clearly, endo skills are essential now.
Absolutely non-negotiable for a modern vascular surgeon. You need to be good at getting access, using catheters and wires, reading the images, managing complications.
First step is always getting access.
Always. Need to pick the right vessel. Common femoral artery, CFA is #1 for arterial, femoral vein for venous. Consider vessel size, flow. Smaller vessels might need heparin if you use a big sheath. Hemostasis is usually easier in veins lower pressure.
Where else can you get arterial access besides the CFA?
Superficial femoral artery, SFA. Popliteal artery, usually patient-prone. Brachial artery, often use ultrasound, risk of nerve injury. Axillary artery, historically infraclavicular, now maybe intramuscular. Bigger but harder compression exposure if needed. Radial artery, good collateral flow but small. Even pedal arteries for complex tibial work.
Venous sites besides femoral.
Internal jugular, often for IVC filter retrieval. Popliteal vein, maybe for thrombolysis.
How do you make access easier or safer? Imaging.
Palpation is still key for the CFA, but ultrasound guidance is huge now. Real-time view means precise needle placement, fewer complications like hematomas or fistulas, especially in obese patients, or tricky anatomy. Fluoroscopy helps too, using bones or calcium as landmarks.
Needles and wires for getting in.
Mostly single-wall needles, now 18 gauge for standard .035 kilo wires, 21 gauge for smaller .018 symbol wires. Once the needle's in, slide in a wire, usually a floppy tip, .018 Singer first. Watch it on fluoro so it goes smoothly, no dissection. Then swap the needle for a sheath, usually 4 French to start for diagnostics. Rotate gently as it goes in.
Okay, sheath is in. Now, catheterization. Wires, sheaths, catheters, lots of options. Figure 62.2, 3 for sheaths, 62.4, 5 for catheters. Tables 62.12 have details.
Yeah, huge variety. Wires differ in tip shape, floppy, angled J-tip, stiffness, diameter, length, standard J-tip for getting started, stiffer, angled wires, maybe hydrophilic coated like glide wires for navigating tough spots or selecting branches. Be careful with hydrophilic wires for initial ISS, though. Theoretical risk of coating embolizing.
And sheaths.
Maintain access. Have a valve side port sized in French units, from 4F up to 11F or even much larger for big endografts. Braided ones resist kinking. Radiopaque markers help position them.
Diagnostic catheter.
Deliver contrast. Again, tons of shapes, lengths, tip designs. Table 62.1 for different jobs. Radiopaque, maybe hydrophilic, braided for control. Size by outer diameter, need to match the sheath's inner diameter. Table 62.2. Usually 4-6F for diagnostics. Microcatheters, 2-3F, for super selective work like embolization.
Two main types, non-selective and selective.
Right. Non-selective, like an omniflush or pigtail catheter, 62.4, have side holes for injecting a large volume of contrast quickly into big vessels, like the aorta. Good for an overview. The pigtail shape stops it moving around during power injection. Selective catheters have specific curves, single curves like a Coupe, double curves like an RDC, reverse curves like a Simmons designed to hook into specific artery openings. Usually don't power inject through these. Crossing catheters help get through blockages.
Getting into the aortic arch vessels from the groin sounds like it needs those reverse curve catheters, like the Simmons, figure 62.8 shows a technique.
Exactly. Usually advance a Simmons 1 or 2 into the arch over a wire. Then you need to reform the tip into that reverse curve, maybe bounce it off the aortic root or hook it across the arch wall, then slowly pull back until the tip drops into the vessel. You want brachiocephalic, left carotid, left subclavian. Simmons 1 versus 2. Simmons 1 has a shorter arm, often easier to handle. Simmons 2 has a longer reach, sometimes needed for vessels pointing more upwards. VTK is another self-forming reverse curve option. Always need very gentle manipulation here. High risk of stroke if you dislodge plaque.
Carotid angiography often start with a non-selective arch shot.
Yeah, usually do an arch aortogram first. Pigtail in the ascending aorta, power inject, maybe 30 milliliters at 15 milliliters. Often an LAO view. Gives you the overall anatomy, origins, checks for problems before you go selective.
But you still need selective shots.
Often, yes. Arch views have overlap. For detailed views of the carotids up into the head, you need selective injections. Use a reverse curve catheter to cannulate the common carotid ostium. Then hand inject or use low-pressure power injection, like 8 milliliters at 4 milliliters, for filming. Can be harder in type 2 or 3 arches where things are more angled. Meticulous technique is paramount.
Vascular closure devices, alternatives to holding pressure.
They are. Things like AngioSeal, anchor and collagen plug for 5 millimeter vessels up to 8F sheaths, Minx, PEG polymer plug, smaller sheaths, CBNF dissolves. ProGlide, suture base like a stitch, good for larger holes too, using multiple devices, the perclose technique.
Advantages and disadvantages.
They can definitely speed up hemostasis, maybe allow earlier ambulation, but there's a slightly higher risk of infection or vascular complications compared to manual compression. Need to choose the right device for the situation.
Power injection versus hand injection. Pros and cons.
Power injection gives consistent volumerit, often better pictures in big vessels, and lets the operator step back from the radiation. But you lose that tactile feedback and can't adjust on the fly. Hand injection gives more control, but requires being closer to the beam. Need to be careful with power injection rates, especially in smaller vessels.
And if you don't use a device, manual compression is still the standard.
Absolutely. Direct pressure, usually just proximal to the skin puncture, compressing the artery against the bone. Time depends on sheath size. Anticoagulation status. Needs careful, consistent pressure. Check carefully afterwards for bleeding or hematoma.
So, successful diagnostic angiography really depends on getting all those steps right. Access, tools, technique, hemostasis.
It does. It's about having a good strategy and mastering the equipment.
Okay, summing up this massive deep dive through Rutherford's chapters 55 to 64, we've covered a huge amount of ground on surgical exposures.
Yeah, from the chest and abdomen down to the neck, arms, legs, even spine access, highlighting those key anatomical pitfalls and approaches.
And the fundamentals of open surgery, the tools, the techniques like endarterectomy and anastomosis.
Right. And then we laid the groundwork for endovascular diagnostics, getting access, the wires, catheters, imaging principles, closure.
It really underscores how vascular surgery demands that deep anatomical knowledge, precision technique,
and mastery of both open and endovascular skills. They really complement each other.
This discussion gives a solid overview, but clearly continuous learning and hands-on experience are essential.
No doubt, this is a field that's always evolving. You need to keep studying, keep practicing, stay updated. The full textbook is obviously the definitive resource.
So as we wrap up, it's fascinating to think about this blend, isn't it? The timeless importance of anatomy combined with the constant push of technological innovation in endovascular therapy.
It really is. That combination of skillful hands and sharp thinking is what defines success in vascular surgery today. It keeps things challenging and rewarding.